So good morning to all. So we welcome you on the lecture number 28. So ma'am, Professor Kavita ma'am will start our lecture on the title Targeted Drug Delivery Strategy for Precision Medicines. So ma'am will start.
Thank you, Leknath. So when we started this course, we started with what is cancer, right? And from there we discussed traditional medicines, right? No, not traditional medicine, traditional therapies. So like chemotherapy, radiotherapy and surgery. From there we went to precision medicine, right? So you find the target and then you attack cancer. Now we are going to go one step further. So even if you have a medicine, okay, which is targeted therapy, okay, even then, if you do not allow it to just go to the cancer, so if you give it systemically, right, it can go to every cell of our body, and although it is a targeted therapy, it can still hurt normal cells. So that's where targeted drug delivery comes into picture. This is called TDD, targeted drug delivery. Okay, so the idea is that you get the drug only to the important site or the cancer site, so the rest of the body is spared. So that's the whole idea. Okay, so first thing in precision therapy is, of course, identify the target. Okay, and once you identify the target, and how do you identify the target? You use different kinds of omics technique. Whenever you hear the word omic means global, organism wide or tissue wide or cell wide. Okay, so you are looking at all the things. So if you are looking at proteins, it is proteomics. If you are looking at genes, it is genomics. If you are looking at metabolites, it is metabolomics. If you are looking at all the RNAs, it is transcriptomics. So that gives you the target. But then if you give a therapy which goes everywhere in the body, it can still be toxic. So now we have to go one step further and deliver the drug only to the tumor site. So in that case, suppose even if you are giving chemotherapy, as long as it only goes to the tumor site, it is not as bad, right? So what are the limitations of conventional therapy? Non-specific distribution, it goes throughout the body, and it will have off-target effects. We don't want to destroy healthy cells, we don't want to attack healthy cells, but it will attack healthy cells, right? And low bioavailability, only a small fraction of the administered dose actually reaches the thing. The whole thing is circulating in the body, liver is cleaning it up, which it is supposed to do. Okay, so only small portion. Now we know kinase therapy, kinase inhibitor therapy is extremely effective, right? Like Gleevec, it is very, very effective, but it has numerous side effects, and see, some of them are listed here. So huge toxicity in the body, although it is a targeted therapy. If you give Herceptin, again, many side effects. So our next step is to get the therapy directly to the tumor site. Okay, so that comes at the targeted drug delivery, TDD system. So the magic bullet concept is that targeted delivery system concentrate the medication in the tissues of interest while reducing the relative concentration in healthy tissues. So you don't want healthy tissues to get impacted. So there are two kinds of targeting, active targeting and passive targeting. Okay, so passive targeting is that you are not specifically targeting, but the drug itself gets accumulated in the tumor site. That would be passive. I'll tell you more about it. And then there is active targeting, that you are really trying very hard to get it to the tumor site only. Okay. So there is this process called EPR, and that is what is used for passive targeting. So what is EPR? EPR is enhanced permeability and retention. So cancer cells are dividing, and then they are going angiogenesis. So they are not very, their whole job is to keep doing it all the time, right? So the blood vessels they make, they are not very nicely made. They are very leaky. So what happens is that whenever you give a drug systemically, it goes, and because see it is broken, the blood vessels are inherently broken at tumor sites, so the drugs will just leak to the tumor. So they are basically concentrated there without any effort from our side. That is passive targeting. So whenever you give a drug, they tend to accumulate at the tumor site because of EPR, and that is due to leaky vasculature. See, it is all broken. Tumors also lack effective lymphatic drainage, so the particles are trapped inside. So that is in our favor, correct? That the drug is getting there. Okay, see, lymphatic drainage is very poor in tumor cells. So that is what it is showed here, that this is passive targeting. It goes and the drugs are mainly accumulated there. Okay. Now I want to say something else here in this slide. So you can also, passive targeting also includes nanoparticles and biocompatible polymers and liposomes. So what they are is that suppose you have a drug and you give it orally just like that, so it is possible that it will be just destroyed in the digestive system, or even if you give intravenously, in the blood also it has a half-life, very short half-life. So it may not stay for very long. So what you can do, you can just package them in many different kinds of nanoparticles. So nanoparticles, there are numerous nanoparticles. It's a very old field now. So you trap the drug inside the nanoparticle, but the nanoparticle does not have any targeting signal. So it's like a drug inside a suitcase, correct? So it is just floating everywhere in the body with no distinction. With EPR, of course, it will accumulate at the tumor site, but then because you have trapped it inside, it lasts longer. So that is also passive targeting. You are giving it to them and it is accumulating there, but you are not really making an effort to only deliver at the tumor site. So that too will be called passive targeting. However, if you take the nanoparticle and attach some kind of, ligand which directly binds to the receptor at the tumor site, then it will become active targeting. Do you see the difference? Package it in a suitcase without address, passive. With exact address, active. Make sense? That is the difference between it. Okay, so now we come to active targeting. So there are many different ways to actively target to tumor sites. So these are some of them are shown here. So let's start from antibodies, right? So antibodies are extremely specific. So if tumor cells are expressing some antigen and you make an antibody, and those antigens are tumor specific antigen, TSA, tumor specific antigen, the antibody will carry the cargo to the tumor site exactly, right? It is writing the zip code, everything there, okay? And it will go there, latch there. And then it will deliver the drug. So I want to ask you one question, first question. How do antibodies deliver the drug inside the tumor? First question. And second question is that what is antibody-mediated toxicity? So first answer this thing. What happens in your opinion? So this is let's say this is a cell, right? This is the surface of the cell. And my watch is something tumor antigen. So the antibodies are coming, okay? Antibodies are coming and they are binding it like this, okay? Then what happens? Once the antibody binds the antigen, what is the next step? Very good, endocytosis. It is taken inside and the drug is also released inside and some of them will go outside. That's one thing. What else happens when antibody binds here? So antibody is Y-shaped, right? So let me now make my hand like an antibody. So antigen is here. The Y-shaped thing is bound here and this is the other lower part of the Y thing. What happens next after that? What else can happen? So this part is recognized by NK cells and all these things. They will come, the antibodies bound, NK cells will come and attack and eat up the tumor cells, right? So that is yet another way of doing it, okay? So you obviously can add antibodies, right? Then you can actually, there are so many things I'm just thinking. You can make specific aptamers. Do you guys know what are aptamers? Aptamers could be DNA aptamers, it could be RNA aptamers. Look at that. They don't have this kind of double stranded structure, not at all. These are secondary, tertiary structures of DNA, RNA aptamers, which are, so you use a process called SELEX, SELEX, and trillions of molecules are made, and then you screen for the things which will bind your antigen or your protein of interest. So you are going for tumor specific antigen, and then if you take aptamer and attach it to your drug, it will only go and bind that tumor cell, right? So that is active targeting. Professor Venkatesh, during his postdoc, worked on folate receptor. So folate receptors are highly expressed in cancer cells, and he took folate compound. So folate will bind folate receptor. So he attached fluorescent molecule to folate, he attached drugs to folate. So then folate, even if you give it as an oral pill or injection, it will circulate and then it will concentrate at the tumor site, because tumor site antibodies will bind folate, internalize it, drug is inside the tumor, right? Or if it is bound there, it will be fluorescent, the tumor will become fluorescent, correct? So it is like it is a diagnostic tool also. So you can imagine numerous things. So all you have to do, you have to look at what is specifically expressed in tumor cells. You attach your drug to that specific thing. If it is a receptor, you attach the ligand. If there is a ligand, you make a receptor, like an antibody is a receptor kind of thing. Make sense? So there are numerous ways of actively targeting there. So that is a very neat way of reducing toxicity of a drug. Okay. So I'm going to show you many examples. So ligand mediated targeting, like peptides, aptamers, or small molecules like folic acid, right? And then I will come to all of these things. So now we are in the active targeting mode. So folic acid, aptamer, carbohydrates, peptide, antibodies, anything can be used. Mainly you put the ligand or the receptor and then the linker and your drug of interest. You can take a nanoparticle and you can decorate it with folate. Now that nanoparticle will only be taken by tumor cells. So many examples. So ligand receptor interaction. Active targeting involves attaching specific ligands to the surface of the drug carrier, and then it will bind to the receptors which are overexpressed in those cancer cells. Okay. Ligands can be antibodies, it can be small molecules, it can be aptamers, it can be anything. Okay. Receptors could be HER2 receptor, EGFR, folate receptor, transferrin receptor. These are different kinds of receptor. And then, as you said, Venkatesh, increase cellular uptake via receptor endocytosis, correct? Okay, so this is a beautiful picture. So this is the targeting ligand, this is the linker, and then this is the drug payload. Anything you want to deliver, you can deliver cytotoxin. Okay. You can attach therapeutic agents, you can attach imaging agents, it will fluoresce. Okay. So you can treat any disease, cancer is just one of them, anything you can. So this is your payload, this is your this is the receptor at the cell surface, this is cell membrane, and this is the ligand for that binds the receptor. Okay. And then the whole thing goes inside. Okay, this whole thing goes inside. This is shown here, aptamer. Look at the structure of the aptamer. Okay, this was very popular in 1990s. So this SELEX method was developed by, I can't remember his name, somebody at Harvard. He was an expert in that, and that was so popular at that time, SELEX method. For nowadays, it's not as popular. It's an old technique. But you can actually create any kind of DNA or RNA aptamer. The other Gyan course I taught in 2016, that's when I talked about aptamers. And then you can attach your drug here. Nanoparticle, see, nanoparticle decorated with aptamers. And then they are taken inside and the drug is released inside. So nanoparticles can be used either passively or actively. Passively, That means you don't decorate the nanoparticle, you just give it, it is floating around. It's like a suitcase. Your drug is inside, but it has no address. Okay, whenever it reaches the tumor cells, yeah, it will release there also, but there is no specificity. But if you put the address, it will only go to the tumor site. Okay, so here this nanoparticle has the ligands expressing. So then then it only binds to the receptor of the tumor cells. But here it is passively doing because there is no decoration outside. Okay. Now I have been telling you about pH sensitive things, right? So today I will tell you about stimuli responsive release. So in addition to that, what you do, you can attach folate and other things, or you can just make something on the outside the drug. So you can attach the drug with something so that it is a prodrug, okay? But it becomes a real drug once that thing is cleaved off, the pro part is cleaved off. And the pro part is pH sensitive. So remember, tumors, they secrete lactic acid. So the tumor microenvironment is acidic. So now you make acid sensitive linker. So that's pH sensitive linker. Then thermosensitive. You heat the tumor from outside, so that when the drug goes there, it is thermal sensitive and it will release at the tumor site. Or you can magnetically guide the drug to the tumor site. So let's look at it. So this is pH sensitive. When it reaches the cancer cells, the microenvironment is acidic, so it will be only released there and it will go in the tumor cells. But here in normal cells, even if they take it, they will throw it out because it's not going to get released in there. Go ahead.
Ma'am, as you said, we will use acidic environment, but in our body there are many different sites where, like in stomach also there are acidic pH. Then
so it's probably not given orally, it's given intravenously, so that it is only in the bloodstream. You're right, because it will fall apart in the digestive system, and there it is extremely acidic. Tumor microenvironment is not as acidic as the stomach. Okay, so look at this thing. They make a nanoparticle which falls apart. So in the rest of the blood's pH is around 7.4, so it is totally stable. And then once it reaches the tumor site, it drops to 6.8. Stomach is 5. It's very acidic. So this difference is enough for the nanoparticle to fall apart and the drug is released to the tumor site. So that is pH sensitive. Okay, now let's look at thermosensitive. So you actually make a nanoparticle which is temperature sensitive nanoparticle. You give it, right, through intravenous injection. Now because of the EPR effect, it will more likely to accumulate at the tumor site, correct? EPR is enhanced. Exactly. So then it accumulates there, and now you have to give a thermal source from outside, and then these nanoparticles will release the drug exactly at the tumor site. Okay, so that is thermosensitive. Okay, now the magnetic guidance is very interesting. So you make nanoparticles which are magnetic. You know, you may be using some kind of beads for purifications which are magnetic, right? So it's a very simple thing to make magnetic beads these days. So you make magnetic nanoparticles and then you use outside magnet to guide it to the tumor site so that they accumulate at the tumor site. That is where it gets really interesting. So you can use magnetic fields to trigger drug release, that it falls apart once it reaches there, or you can also guide them to the right place. Okay, so it can be used in both ways. People have made a sperm hybrid micromotor. So this is a sperm. It looks like a sperm and it has drug loading here. Okay, and then they make this whole thing as a magnetic thing, so that they guide it to the tumor, and once it reaches there, it just shoots the drug in there. Okay, so that was stimuli responsive release. Now we come to nanocarrier tool bags. So nanocarriers are nanoparticles. Okay, so you guys, all of you have heard of nanoparticles, right? It's a pretty old field now. So there are many different kinds of nanoparticles. These are the oldest one, lipid-based, liposomes, solid lipid nanoparticles. So how did this idea come? The membrane, the cell membrane, it is made of phospholipids. So that's how the idea came, the first idea, that what happens is that the cell membranes are hydrophobic, right? They have this kind of structure, right? You know, there is this hydrophilic part here, then the two tails, and then it is bilayer. So the two layers react with other two layers, non-covalent interaction, and this is hydrophilic. So this is hydrophilic, water outside, water inside, right? So initial liposome was derived from that idea that you make small vesicles of lipid bilayer and you pack stuff in there, and this lipid bilayer will fuse with the cell membrane, throw the stuff in there, right? So that was the first one. Then people just used all sorts of nanoparticles. Okay, so I'm going to show you. So look at this nanoparticle here. So this is the outside and this is the inside, lipid bilayer like, right? You can see here. So this is hydrophilic, inside is hydrophobic. So the molecule goes in because the lipid layer is hydrophobic, it goes in there. Hydrophilic can also get in there, fluorescent dyes can get there, and outside you can attach active targeting agent. You can attach an aptamer or folate or anything you want to attach, or antibody or peptide which will recognize specific places. So you can actually make a nanoparticle for active targeting. So this is just to show you all different, people have been extremely creative here. So polymeric missile, reverse missile, all sorts of missiles. Is there anyone working on nanoparticles here at IIT Indore? Probably not, right? Yeah, it's not a very new field here. Faculty members. Okay. Yeah, so nanoparticle is still a very interesting field. Look at all of these different kinds of nanoparticles there. Okay, so magnetic nanoparticles and nucleic acid, and this is acid activable. So if you put it, this will be activated in the tumor microenvironment. Magnetic, okay, so many of them. And this is a dendrimer kind of structure. So this is conjugated drug all around it, right? So you want to make a nanoparticle which is made of something which is biodegradable so that it doesn't cause too much toxicity. But having said that, people make gold nanoparticle because gold itself is used for therapy. I think in one of them it said, or maybe it will come, it shows that gold actually is used for therapy. So you can see different kinds of things. So there is one very important thing about nanoparticle, okay? So there is something called homotypic targeting. What that means, I will show you that once again. If the two cells are of same kind, same cell membrane, right, then they will tend to interact with each other. So what they do, they take the nanoparticle and put an artificial membrane to mimic inside membrane, and then it will be interacting with each other. That is called homotypic. So what they do, they take the cancer cell membrane to mimic it and put the nanoparticles around this thing. So they will go to the cancer cells, like attracts like. So cancer cell membrane carrying nanoparticles will reach the cancer cells. Can you tell me another cell line which can target to cancer cells? If you have to package some cargo to tumor cells, which cells will you use? Mesenchymal stem cells, they are very good. They are very good. Trojan horse. They will find the tumor cells and they will go there. Okay. So inorganic, yeah, this is here. Why use inorganic nanoparticles? Gold nanoparticles are biocompatible. They have unique optical properties which allows for photothermal therapy alongside drug delivery. These days photothermal therapy is becoming very important. I have quite a few friends and collaborators who are working on photothermal therapy. Okay, so and similarly you have other kinds of these things. If you use iron oxide, it can be used for MRI imaging. Okay, so the point here is that there are many kinds of nanoparticles, and again if you decorate them with proper ligands, you can actively target them to the cancer cells. Okay, now guess what, immunotherapy is given just like that, just like in this, but they can also be packaged in nanoparticles and deliver it. Okay, so PD-1, PD-L1 inhibitors are antibodies, are directly delivered to the tumor microenvironment packaged in the nanoparticles, and these nanoparticles are loaded with PD-1, PD-L1 inhibitors, and you can heat it up so that they are only released at the tumor site. So you know, PD-1, PD-L1 therapy is so effective to start with, but if you add a nanoparticle to it, it's even better, because then there is less toxicity to healthy cells. Okay, all right. So now it is released just next to the tumor site, so it reduces toxicity. You guys already know about antibody drug conjugate. I'll tell you briefly. So this is your antibody, and now you attach the drug of interest using a chemical linker. And you guys already know that antibody will bind to the tumor site, and then the drug will be released next to it or inside it. And if it is released next to it, the tumor cells which are not even binding the antibody, because the drug is in the vicinity, they will be killed. And this is called bystander effect. Bystander, remember that. Okay, so this is a very important thing. Suppose the tumor is heterogeneous, which it is, right? So some cells are expressing the receptor for this antibody, so this antibody binds the receptor. So some of them will be taken inside and drug will be released inside, and when the cells die, the drug will be thrown out, or some antibody will bind and the drug will be released there, and then they will attack other cells which do not even express the receptor, but it is within the tumor, correct? So it will kill other tumor cells, and this is called bystander. Like they are bystanders, right? They are just standing there, they are not doing anything, but they will get killed, which is very good, right? Because these are tumor cells. So that's what it is shown, that you give the ADC, it is taken inside and the drug is released, and then it will inhibit and the cells will die. Same thing here. Okay, so target site has HER2, antibody will recognize it, this is your drug, and this will be released. Okay, so this is the actual drug. You know, Herceptin is so good without the toxin. Just binding there activates, this part basically activates the immune system, and NK cells will come eat up. And if you attach a bad drug to it, which is a microtubule inhibitor, that is really good. So this drug becomes very good. This drug is called Kadcyla. Okay, so this is what I was telling you, bystander killing effect. So ADC binds to receptor, endocytocyst, and the drug is released here. This drug, some of the drug will be released from the antibody, and then all the other cells which are close by will also die, although they don't have the receptor. So you are even targeting heterogeneous tumor that way, which are not even expressing. Okay. All right, biomimetic carriers, nature's disguise. So homotypic targeting is binds to the same tumor type. So natural extracellular, so what happens, do you guys know what are exosomes? Have you heard of it? How many of you? Not all of you, but some of you, right? So exosomes are vesicles secreted by cells. So what cancer cells do, they secrete these small exosomes. These are like nothing but small vesicles, and inside they will put microRNA and oncogenic RNAs and things like that, and they will go to innocent cells around which are not cancerous and go inside and fuse there, and once they fuse there, those genes will be expressed and those cells will become cancerous. So now we can use the same trick and package our drugs in exosomes. and give it to patients. And that will work very well. So what is the advantage of using vesicle? Because the immune system does not attack it, because it's the same thing which is there in the body, right? So immune system let it go, and you can actively target exosomes to the tumor also. Okay, and it also can cross blood-brain barrier. So look at this thing. You can make exosomes having different kinds of packaging, like different kinds of suitcase to package your material in. You can use mesenchymal stem cell membrane. Okay, now they're going to go to tumor site. You can use red blood cells. You can use platelets, outside part. You can use immune cells, cancer cells, and all of these things will take the cargo inside. Okay, so this is just cell membrane coating. This is to fool the immune system, and you can get all different. See, all of them are different kinds of cell membrane coating. Okay, so this is biomimetic exosomes. So you can say mesenchymal stem cell membrane. You put your stuff there. You load your drug RNA, give it to the patient, and it will work. All right. So scientists are very creative. Okay, gene delivery vehicles. So this is gene therapy. Okay, so so remember I was telling you about transfection and viral infection. So transfection will not work in humans. Okay, because even if you work with cells, it is very inefficient. So there is no way it will work with humans. So whatever DNA, suppose somebody has cystic fibrosis, right? And you want to deliver the correct gene for cystic fibrosis. You cannot give the DNA, it will get degraded in no time. So you have to package it. So you have to make a virus which is not bad for the human, but it goes to the target site and releases the DNA, and that DNA becomes part of the host chromosome, and then the gene is expressed there. So those are viral vectors, and there are many different kinds of viral vectors like lentivirus, adenovirus, this kind of thing. So their efficiency is very high. If you put it in lipid nanoparticles, it's very poor. It says moderate, but it's pretty poor. Immunogenicity, because it's virus, the immune system will get activated. The immune system is fooled by lipid nanoparticles because they look like just lipid bilayers kind of thing. You can put limited cargo size because virus has that much space in there. You cannot put huge things, but here you can make large nanoparticles, package a lot of this. Viral vectors are relatively expensive, but the beauty is that it is permanent gene replacement. So that is the way to go. These are, I'm guessing nobody has worked with viruses like I asked you before. So these are extremely easy to work with. These are pretty old things now. Lentiviruses came out in 2003, so we have been using for 22 years. It's very old. Retrovirus I've been using since the very beginning, since it was discovered in 1990s. Okay, so the guy who discovered retrovirus, he was in David Baltimore's lab. He was a graduate student, and he came to Princeton for postdoc, and that's when I started my postdoc. So we started almost at the same time. So his advisor got the Nobel Prize for retrovirus discovery, and the guy who discovered it was a postdoc next door. So I learned from him. So I've been using it. I was fortunate to be in touch with him. So I'm learning it from the guy who discovered it, who actually found it. Okay, so the point here is it's pretty old now, and it's very, so you take the vector in the genetic material, make the virus, it infects, and it becomes part of the host chromosome. So this is very good. You can directly give the viral particle, or you can make a cell line infected by viral particle, and you can give it to the host. And the beauty is that it can cross the blood-brain barrier also. So if you have to do something in the brain, you can treat it that way. Okay. Now, in addition to that, many of you know that, have you seen like people wear patches where insulin is pumped to them all the time? We wear watches which is keeping track of our heartbeat and all the other things. And people who have sleep apnea or atrial fibrillation, these smartwatches can actually keep a track of everything. So these are these are other things. Okay, so insulin diabetes, artificial, we call it artificial pancreas. It's not a pancreas obviously, but it is constantly monitoring glucose and it has insulin pump. Actually, this is very surprising. In 1999, when I joined Novartis, I needed insulin for my experiment, and it was all open lab. It was one company, like the money was company's money, so sharing was not like my money, your money, it's the same money. So I asked this guy, do you have some insulin? And he was joking, obviously. So he lifted his shirt and he said, I have an insulin pump. Do you want me to take it out? It was very scary to see that. So, but it was a point, I had never seen it, right? But the point is that it is that old. People were using it at that time. Okay, so there are microchip implants that release precise doses of osteoporosis medication or hormones programmed on program command or remote signal. Okay, there are also patches for nicotine or something, so that is becoming pretty common. Okay, so key challenges with targeted drug delivery: target heterogeneity. You target it for one thing, you can deliver it, but the tumor itself is very heterogeneous. So the cells you are targeting will die, but the ones which will not die will take over. So that's the problem. Immune system attacks. Oncolytic viruses are our favorite, but they don't survive, right? Toxicity. Okay, that nanoparticles can themselves be toxic. Synthesizing a simple drug is easy, but when you make nanoparticles, you can have batch to batch inconsistency. And if you make a complex nanoparticle, it can be tricky to synthesize, and high production costs can limit accessibility to these nanoparticles. Okay, so future look is that we use AI in career design. So predictive modeling, material scaling, personalized optimization. Our 30th lecture is all about AI. Okay, so you will learn a lot about what AI is doing in that area. Okay, sounds good. Okay, so conclusion is that we have to be precise, safe, and effective. So, okay, then I have put 2 slides which have nothing to do with targeted drug delivery, but it has to do with our discussion, right? So remember we were discussing if somebody is diagnosed with liver cancer, you suggested let's open it up, do the biopsy. I said no, it's not a great idea, right? So then I found this thing, and it will make us feel very good about it, that liquid biopsy can detect the biomarkers in many different cancers. Okay, so we don't have to worry about opening up a patient and looking at it. So what happens is that these tumor cells shed DNA, tumor DNA in the blood, and you just take out the blood and you screen for it. Okay, so for lung cancer it is extremely good, very effective. Colorectal, very good. Breast, prostate, ovarian, brain, even early stage solid tumors. So you can do liquid biopsy. And when somebody has cancer of the digestive system, even taking this tool can be very effective. So for bladder cancer, urine is the best way, no invasive surgery. Lung cancer, blood plasma. Brain tumors, cerebrospinal fluid. Okay. Cancer, plasma, saliva. Okay. GI cancers, plasma stool. So we don't have to open up the person at all. We can just directly do the biopsy, analysis that way. So finding out what's wrong is much easier than what we thought. Okay, all right, that finishes up the first lecture.